Hello everybody, this is part 2 of lecture 7. We just got done talking about the ASAM and all of the parts of the ASAM, 6 different dimensions, how to give each one a severity level from 0 to 4, and how to come together using all those pieces to determine a level of care that you would assign for that individual. So now following up with that lecture, we're moving into the level of care and the variety of levels of care that you can assign to an individual. Of course, wherever you're working, you're going to be possibly working for an organization that already has a provided level of care that they give. If your client does not if their needs do not fit within the level of care that is provided by your organization, it is very important that you're able to, that you are familiar with referral sources in your area that can provide a necessary level of care. Many organizations are going to have outpatient or intensive outpatient, or other places will have explicitly residential or inpatient. You'll also find other places that have partial hospitalization treatment services as well. So it's good to know what's available in your area, so that if you do find that somebody has a higher level of care than you can provide, that you have those services available. Right here we see all the different levels of care that are provided, that are options to provide. First is early intervention, screening, and education. This would be what we consider short-term therapy. We're only planning on seeing somebody maybe 2 months tops, just to give some brief intervention, education, and skills, things like that. OTP, or opioid treatment program, is fairly unique. This would be if somebody has been prescribed Suboxone to try and gradually taper down off of a very high amount of opioid use that they may be addicted to. This can be a very long-term process where you're going to be required to help coach the individual through gradually tapering out of their use of an opioid. If this individual has been prescribed an opioid from a licensed physician, then that physician should be requiring this individual to go to regular treatment to continue managing stressors and finding ways to get better. The ultimate goal of any maintenance program or opioid treatment program is to eventually get to abstinence and relapse prevention. Next up, level 1 is outpatient, which is any form of treatment that is less than 9 hours per week in an outpatient setting. 2.1 is the intensive outpatient treatment level, which can also include partial hospitalization, and that is any amount of treatment that is at 9 or more hours per week. 3.1 to 3.7 are various levels of residential and inpatient treatment depending on the specific services and care that are provided at that particular center. And then 4.0, the highest of all, is the medically managed inpatient, which is any hospital setting of any sort. So I'll talk about all those different hospital settings. And really, this is supposed to be the most limited time of all these places that that somebody may be prescribed to. It should be only if they're dealing with severe or difficult problems of instability from dimensions 1, 2, or 3, where they would require 24-hour medical services. Really, it's only the first 3 dimensions where somebody would be required to be hospitalized. The first one being severe withdrawals and intoxication, the second one being severe mental health difficulties, where the person may be actively suicidal, and then the third being medical issues that have become out of control and require immediate hospitalization. I think I got those in the wrong order. Yeah, it's withdrawals, medical, and then mental health. But, you'll get those. So first off, outpatient treatment considerations. If you're just going to see somebody on a weekly basis at an outpatient center without any sort of formal group services, then these are the 3 things you should ask yourself if this is appropriate. First, can the client safely manage his or her own prescriptions and independent living needs? That's probably the first and foremost question for somebody who may be having co-occurring disorders. They are, by definition, going to be struggling quite a bit if they have a co-occurring disorders diagnosis, and so we have to be able to determine whether or not they can live on their own and get to sessions on their own. A very important question for outpatient treatment. Next, is there a positive relationship and alignment between the client and the therapist, and do you both agree on the recommended goals? These are all the most critical questions to ask if somebody is going to be an outpatient, because outpatient treatment is not going to be effective unless there is potential for a strong alliance. Now, the first session or 2, there may not be that alliance built yet, But really, this is something that can be determined within the first few minutes of meeting a new client, getting a sense for how you and the other person interact. I mean, we like to think that if we were trained perfectly, that our personalities wouldn't matter, but they do. And whether we like it or not, our personalities just are going to match better with some people than others. And being able to work on our professional skills of working with the ebb and flow of somebody else's goals is going to help you be able to be in alignment with your client, but we also cannot expect that from ourselves to be good with everyone. Next up is intensive outpatient, IOP. Um, must meet for at least 9 hours per week is one of the primary criterion here to be considered an outpatient setting. That's going to be a lot of group sessions. Typically, you're going to get about 9 hours of group sessions per week with some form of individual therapy, maybe every other week. Usually 3 to 5 days, at least 3 hours a day. It's going to depend on the program, what they offer. The Matrix program is something that I was trained in. Back when I worked for a CMH organization, they used the Matrix, which is just basically a structured approach to creating an ILP that gives you all the different hands-out and topics to work on for a variety of different groups. Another important treatment program out there for adolescents is the Adolescent Community Reinforcement Program. So just a few of them to keep in mind out there. You may or may not already be familiar with an IOP or intensive outpatient program in your area. Very good to know where they are and how effective they are and how well they're run. A served community treatment is another form of CMH provided program. This one is not oftentimes just one thing. It's a variety of different resources provided for somebody, more in the line of case management, but it's multidisciplinary as well, and it's considered a form of outpatient support. The emphasis is working in the home, so this may be a lot of in-home work where you're actually going to people's places, which is different than what we consider standard outpatient or intensive outpatient. The resources are many when it comes to an official assertive community treatment program. They include case management, where they're helping you get set up with community resources, nursing services, peer specialists, client-run teams, substance use treatment, vocational counseling, specialists, so crisis, a little bit everything. So this is a very integrated program that is considered overall a form of outpatient support, but it's much more than just going in for groups every day. Another form of outpatient that is the closest to being residential is a partial hospital program. This is closer to more of a residential program than it is hospitalization, so the term there can seem a little misleading or confusing. This is not like being hospitalized at all. Hospitalization is the most intensive, and partial hospitalization is not even as intense as being in a residential care facility. This one is a step down from inpatient hospitalization, but it's also more so a step down from residential or detox. Basically, this is a program that's run 5 to 7 days per week, 4+ hours per day. You can access all the service there all the time. It's pretty much a place where you can just walk in, get what you need. Typically, they would like you to stay there for all or most of the day, unless you've got other things going on. The only time you really shouldn't be there, they expect you to go home at night. It really depends on how the organization's run. Personally, I have not seen any partial hospital programs. I don't think we've had any in Kalamazoo yet. We tend to mostly run through intensive outpatient programs, which is unfortunate. I think the Grand Rapids area has a partial hospital program, so I'd love to see one someday. I'm sure it'd be possible to also have night services at one of these too, to work as a 24/7 facility for people to come into, but as far as I know, it's usually just run during the day. You need to have at least 20 hours per week of programming for Medicare coverage to be considered officially PHP or partial hospital. So basically that means they'd want you there for at least 4 hours each day during the week. Once again, this is supposed to be a one-stop shop where you can go to get group, individual services, family treatment, psychiatry, nursing, labs for testing, medication management services. Can also include detox or withdrawal services if you can do that during the day. But yeah, it's just supposed to be a place where you can go spend a lot of time there, which it's a great idea. I wish I could see one of these some days because, IOP is nice. That's why I've seen a lot of IOP, but people have to get there and then they have to leave, and it's not easy, and a lot of them would like to be there all day because they have nowhere else to go. They have not much else to do, and we got to kick them out basically. They can't spend much more time than that. But I think being able to make a real give people that kind of sense that they can be there as long as they need to is a great thing for whatever they may need to get. So one more step up is inpatient, and we want to be able to look at some of the particular indicators. So these are things that you would note, particularly in the ASAM, that would basically justify going into an inpatient level of services. Some of the big ones are suicidal or homicidal behavior, or thoughts and plans of wanting to commit suicide or self-harm. Having a history of severe withdrawal symptoms, and a very strong likelihood of them experiencing more intense withdrawal symptoms in the immediate future, right? So you've got somebody coming in who's recently been highly intoxicated on a substance, and they tell you they've had really bad withdrawals in the past. That's somebody who's very likely going to need inpatient or detox services. The same thing as if they've been using a combination of different drugs, where there could be dangerous withdrawal symptoms expected as well. Even worse than heroin and benzos would be if someone was using benzodiazepines and alcohol. Those two drugs in combination have a very powerful interactive effect that can really create a lot of difficulties. Oh, looks like I got off track there. Here we are. Another one is severe disorganized or dangerous behavior, so this would be a possible threat to others or self. Major deficits in self-care, so this would be somebody who may be impaired in some level and may not be able to safely take care of themselves or get home. And maybe more so among the elderly or disabled in other way that they may need this extra services. Serious relapses, so the nature of how they relapse can be a really big part in this. You know, I've had clients before who, when they relapse, they cannot eat anymore. They become constantly nauseous and malnourished, and that would be someone who would be of high risk and high need to be in an inpatient setting. And then also motivation and preference. If somebody really wants to spend their time in detox or a residential center, more likely, you really can't make someone go to detox unless they have the medical reason to be there. But if someone really wants to spend 2 weeks in residential, you know, without the detox nursing services, then they should be more than welcome to. Important distinction to make there between detox and residential. Detox, you know, or as we said before, withdrawal management services, it requires a nursing unit to be available and present. So you're basically in a clinic when you're in detox or withdrawal management services. In contrast, residential services is basically you're living in a bunk and you're getting up, and it's a structured day, and you go to a lot of different treatments, you stay on site, they feed you, they do all that, and then you go to bed at the end of the day, and you usually spend anywhere between 2 weeks to 3 months at one of these or longer. But the main difference is whether or not there's nursing care. And a lot of places have both. Like, you go from the detox center over to the residential once your withdrawal symptoms have mitigated. So just good to keep that in mind. As we were talking about this, detox versus residential, specializing in withdrawal management, as we mentioned before, that's the detox part. Typically for alcohol, benzodiazepines, and opioids, but really a wide variety of substances can come with very distressing withdrawal symptoms. May include Subutex tapering for opioids and transference to a maintenance treatment program. I talked a little bit about Subutex, which is a form of buprenorphine, which is a replacement opioid that's less severe but can help taper people down. Like I said before, residential is usually 2 to 4 weeks or longer. Your treatment directly following detox services. Typically, you want them to go straight from detox to a residential program. This can also include case management services to find a job and transitional housing if they didn't have housing before they went in. There's also another really important thing to keep in mind. A residential program may or may not be properly equipped to deal with people with severe co-occurring disorders. So there is another subtype called co-occurring enhanced programs, which may specialize in things like schizophrenia, severe PTSD, or other personality disorders that some programs may not be qualified to be able to manage those types of services. Think about it. Residential center, you have all these people 24/7 around each other. That's going to cause a lot of interactions, a lot of shoulder bumping. You need to have people properly equipped with the right de-escalation techniques, therapeutic techniques to help keep that type of center stable. And of course, we talk about medical and hospital acute units. Typically, these are considered unlocked or voluntary. People aren't going to make you stay. In fact, typically you can't make anyone stay to any of these. They can always leave. It's part of, informed consent that people can always leave services. Can provide sitters, so people who are monitoring regularly to make sure that there is no immediate threats that aren't being observed. Client only stays until the active or medical safety concern has been addressed. So that's the most important thing to keep in mind. You're going to see this out there all the time. People get kicked out of hospital settings as soon as the major risk is over, whatever it was. As soon as the medical issue is resolved, as soon as suicidal ideation is resolved, whatever the main issue is, they're out. So this is not a place people can plan to usually stay very long, which means they have to have some kind of resources set up directly afterward. Other hospital settings, community, state-run, freestanding, Veterans Affairs. These are all just a variety of different types of hospital settings that people can be sent to if they do have some significant risks of self-harm or other forms of harm going on. But I won't go into too much detail on these. There's a lot of writing here that you can feel free to look over on your own time. Veterans Affairs hospitals, those I can say for sure are an important resource to make sure that if you do have a veteran clinician or a veteran client, be sure to let them know if there's any veteran services nearby. Alright, so now I'm going to review the Maguire et al. Article a little bit. Just some of the main factors. First off, the purpose of this article was to ask this question and answer it. Does accurate placement of care, level of care, significantly affect treatment outcomes, right? Good question to ask, right? With all these levels of care that we just covered, does it make a significant difference for someone? And when you read this article, don't worry about their selection methods. I found them a little bit confusing, right? Like, what was the difference between the random computerized form versus the clinical form? Don't worry about that. Just make sure to keep the main parts in mind when it comes to the method, which is that there were 3 levels of care offered: regular outpatient, intensive outpatient, and inpatient, and that they used 2 different levels for determining what level of care placement that they were going to be put into. One was a computer algorithm and the other was clinical evaluation. They tried to use ASAM criteria for both, but one was supposed to be more randomized than the other. And basically, the outcomes, what they found are a couple of important things that were noted in this study. One was that providing regular outpatient services when IOP was recommended predicted poor outcomes. So they actually did find that putting someone in IOP if they need IOP was pretty important to do. Another interesting thing they found out was that providing IOP when detox was recommended did not produce negative results, which is a very strange thing, right? This article is a good one to read just to get the idea that they're trying to put out here, which is, does level of placement matter? That part would surprise many people to hear that detox was not as important, or wasn't as critical. If somebody needs IOP, it does seem to be that IOP is a good place, a good placement for somebody, even if they do properly need detox. Now, the one reason why they may have found this is because there was a pretty big limitation. There may have been selection statistical power issues, which just basically means that their sample size may not have really been big enough to draw any broad or sweeping conclusions. So just keep that limitation in mind. This was just a good experiment to see whether or not level of placement made a difference. And it's good to see that in some ways it does, some ways it doesn't. But once again, it's going to come down to every individual. There is no perfect solution, no perfect silver bullet for anybody. Alright, so here's the lecture response for this week. I want you to provide a severity rating for at least 3 dimensions of the ASAM for John here. Basically read through this story, and this story will be on the lecture response for you to look over there. And pick 3 of the different ASAM parts that were explained in this lecture. And just give 1 or 2 details for each of those. Then assign a level of care for John. And determine 1 extra question that you would ask John to try and help you improve your level of care recommendation. Keep this short, just to the point. Pull out whatever you can from this little vignette here, and just do your best to give a little bit of detail. As usual, I'm not scrutinizing these lecture responses super deeply, so just do the best work you can. Hope you enjoyed this lecture, and let me know if you have any further questions.